as we are nearing through the second semi exam, don't take pictures, these are not exam questions. Well, we can frame 100 or 1000 questions based on like clinical courses in anatomy. These are quite common examples found everywhere. But the point is not about the question, how we are approaching to the clinical problems. So whenever in an anatomy section, you are given with the clinical problems. Say for example, pain in case of appendicitis is referred to the skin around umbilicus. So if you are approaching any question or referred pain refers from the cholecystitis or gallbladder issues to the tip of the shoulder on the right. So any anatomical questions which ask you to correlate the thing clinically, why this thing is there and going somewhere else. So basic thing what the anatomy people are looking here is what do you understand the anatomy or not. So whenever you are explaining the thing, start with the root. Like if you are stating this appendicitis, you have to talk about the appendicitis, like appendix, what is appendix and what is appendicitis, like infections of the appendix likewise. And then if it is referring to the pain, that means it is something related to the neural connections that you have to find. That means a pain, that means who takes the pain? Blood vessels or nerves? Who takes the pain? Nerves, okay. So you have to find the nerve connections to it. So that is a pain with an organ connecting between that, we have a neural connections. That's what you have to establish. Now that particular connection that you are seeing here in case of acute appendicitis or cholecystitis or gallbladder issues, you have to understand what nerve is carrying there and why that particular segment of the body is representing as a pain domain like tip of the shoulder or appendix around this particular umbilical region. So you have to find a reason why that particular pain carries through some nerves and referring or landing up in umbilical region or tip of the shoulder. So you have to line out how this pain is reaching to that point. That's the justification, that is what you have to find. Or else commonly what you have to see, a patient is coming on the tip of the shoulder pain, right? Now at the tip of the shoulder pain you must have thought of like something have paining in the tip of the shoulder may be related to the direct relations or on the injury on that particular site. So that's what you have to understand. If you have a fracture on the shoulder region, you may have a pain there. So you have a direct trauma on that shoulder region. Now in this particular case of acute cholecystitis, the patient do not have any direct blow to the shoulder region, yet he is feeling pain on that region. Now how that particular person is not having a direct blow to that particular organ is feeling pain. So this is what is an understanding of your anatomical correlations with the organ itself. So a cholecystitis pain is referring on the tip of the right shoulder, that you have to see that a nerve is bringing the pain and that particular nerve is bringing the pain from elsewhere, not in that particular site. So we call this phenomenon as referred pain syndrome. So it is paining somewhere actually, but is referring to somewhere else. So that correlation, that what you have to find it. The nerve which is responsible to it and why this particular pain is relatively referring to the tip of the shoulder, not anywhere else, not in the elbow or not in the wrist or not on this particular lower limb. So that's what you have to understand, this particular relationship. So you have to explain in this particular question, what do you mean by the gallbladder, what is the nerve supply to that particular region of the gallbladder region, and on that particular contrary, this particular gallbladder is situated in the undersurface of the diaphragm. Now this particular organ itself is paining in this particular region, of course in the epigastric region or right hypochondric region, but yet it is sending some signal on the right shoulder tip. So they are asking you to correlate the pain where they are the gallbladder issues or pain or irritation under the diaphragm is referring to the tip of the shoulder, that is carried through the phrenic nerve out of that we have two phrenic nerves, right side and left side. So disease and pathology, irritations of the right phrenic nerve is irritated, and that particular phrenic nerve has a dermatome root value of C3, C4, C5. Of that, C4 is a predominant nerve contribution. C4 dermatome is on the shoulder region. That's why that particular pain is beside over this particular anteabdominal wall or epigastric region, is also felt on the tilt of the shoulder region, because that pain is carrying through the C3, C4, C5 fiber, which has a skin supply on that region, feeling the pain. So you have to understand this particular anatomy which is linked to it. Similar thing with this umbilical region. It is carried through the spinal nerve T10, and the T10 dermatome is around the umbilicus. That's why the pain in this region, right side, is also felt around the umbilicus as block, because the same T spinal nerve which is going to the spinal cord is giving to supply the skin over this umbilical region, and the patient is feeling the pain on that umbilical domain besides this tender McBurney's point. So you have to understand the anatomy, you have to explain the nerve supply, and we have to see that why this nerve is bringing that pain to that particular section with a schematic picture like this. That's it. So this is what you have to explain, how this particular thing are going on. So gastric ulcer common on lesser curvature. So you just cannot jump into the gastric curvatures right way. You have to say that what is gastric curvature? It's present on which organ? So stomach, if you say stomach have two curvatures, why it is prone to have more on the right lesser curvature than that of greater curvatures, etc., etc. Blood supply or any issues related to that particular region, any problem which is staying prolonged time on that parielope region, so on, so on. That's what you have to explain anatomically, why that particular point is vulnerable for that kind of injuries, where the fundus of the stomach is not getting the insult, the body is not having problems. So this particular organ has a problems over here. Varicocele is more common to the left side. So you have to understand what is varicocele, which organ suffers varicocele. What do you mean by the varicocele? Is a kind of dilatations of kind of veins. What kind of veins? And why this particular vein dilates in a particular side more frequently than that of counter side. So this is what you have to make sense. So 4-line, 5-line explanation, not big essays, with a schematic diagram why these things are going on. So this is what you have to explain in anatomy whenever you are doing it. Say for example, paramedian incisions in the abdominal wall, how this rectus abdominis is retracted. So you are pulling this muscle if you are going to do a surgical incision. Now you are saying that this muscle you are pulling to the lateral side. Now what is the logic? Why you are not pulling it to the medial side? Because we have the neurovascular structure coming from the lateral side. If you are traction putting on towards more in the midline, you are pulling them apart, you are ripping them off. So to save those neurovascular structure, you are pulling them towards this less traction side. That's a logic, that's a common sense. Well, I can do that any way I can do, but what's the best way of doing these things, right? So this is what we talk about related to this particular clinical problem. So whenever you are coming across any clinical problem, find the anatomical logic, find the reason for it, why you are doing this commonly, why it is practiced. Is there any logic for it or is no logic? There has to have some logic which you have to explain anatomically, not the disease, how we are going to treat these or blah blah blah, those things are not. You have to explain this particular anatomical facts with this anatomical reasoning, not with the clinical clinical problems, how we are countering on these particular structures. Now coming to from here a quick revisions of this content that we have learned so far, embryological developmental sessions that we have learned in this particular subsequent frequent classes, a quick review of the thing that you must understand over this particular region of development of these particular urinary systems. The phenomenon I have mentioned, this particular story, how this particular thing is formed, you have to know. But more importantly, you have to understand this particular clinical problems related to this particular development or developmental error, which is our exam questions. Now for that regions, you have to understand how this particular organs is developing, and if there is any significant developmental changes that is happening over here. Say for example, in the renal system that we have learned like beforehand, the kidney. Now we learned that particular kidney in adult, we have the 3 sets of the kidney replaced by one after another with a better version. So we have 3 sets of kidney, but eventually we get into a kidney which develops in this lumbar region. We call them as the adult versions, also known as metanephric kidneys. Now this particular metanephric kidney is developed in this particular region, lumbar region, and eventually we see that kidney placed under the diaphragm. So this particular kidney made a subsequent change in positions from this lumbar or this particular pelvic cavity to this part. So it keeps on climbing. We call them as ascent of the kidney, but it's a kind of like a false statement if I call it as a ascent of the kidney. The kidney never climbs through ladders to this particular subdiaphragmatic position. Actually, this lower part of the abdominal cavity grows or elongates more. As a result of that, it's an apparent change in positions of the kidney position. So it is growing more in lower positions, rest of the organ is coming down. As a result of that, kidney staying there and moving in upward directions. Now, as this particular thing is going upward in position, there is a counter organ which develops along with the kidney, which is the organ we call them as gonads, testicles and the ovary. Makes a switch changes, the kidney climbs up or moves, ascends upwards, where the gonads comes outside of the abdomen cavity. In case of the male, it settles down to this scrotal sac. In case of the female, it settles down to the pelvic cavity. So there is a reciprocal change in position between the kidney and the gonads that is taking place. Now, as this particular metanephric kidney goes in changing in positions, it changes the blood supply, which is important for us. So it keeps on changing the blood supply, updating it as it moves from this particular lumbar region to this sacral region to the lumbar region to this particular abdominal. So these branches of these particular arteries which is coming from the abdominal aorta, it keeps on changing, like internal iliac arteries to the lumbar arteries to this particular renal arteries to the final stage. So this particular arteries or blood supply of the kidney keeps on changing through this particular developmental process. That's what we have to understand. Now, during this particular change in posture or change in positions, what happens? We have some kind of excess arterial system that can happen to this particular kidney in positions. So this artery which the kidney is changing should have normally regressed. If it fails to regress, we have an extra pair of arteries present and feeding these kidneys. We call this artery as accessory renal arteries. Now, here is a catch about this accessory renal arteries may be the sole blood supply of the kidney itself. That's what you have to keep in mind. So you have to keep an open mind whenever you are understanding the blood supply of the kidney. So far we know that kidney is supplied with the renal arteries, that's for sure. Now, as the kidney keeps on changing these arterial sources, there may have some developmental blood source error that leading to non-formation of renal artery itself, rather than these accessory arteries or old primitive renal arteries may be present and may be present as the sole sources. So this kidney is supplied with this particular accessory arteries in the lower pole of the kidney, and it is the only source may have or may not have the renal arteries supplied to it. So this accessory arteries is a trouble for surgery, that's for sure. But it could be more trouble if that is the only source of renal artery which is supplying or feeding this. That's what you have to keep in mind. Now, why these accessory renal arteries are more frequently seen? Because kidney changes its blood supply. So as it goes down from lower position to higher position, it changes this blood supply, and sometimes it may forget to arrest that arteries. So that artery may have present as an accessory renal arteries, which is present more commonly seen that lower pole of the kidney. Why? Because kidney is taking the blood supply from low to high up. Now, this accessory artery, if it is present, it's a problem for the kidney itself. One problem it could have, it may run over this particular ureter as it is going down and may put a finger or put a pressure on this particular ureter or the renal pelvis, blocking this outflow of the urine, resulting in the dilatations of the kidney and this ureter. We call them as hydronephrosis, hydroureter. So this can have a compression effort on this kidney system and the urinary outflow system. So this particular problem may be there. During surgery, if you are not experienced enough, you are not expecting these accessory arteries, you open up the kidney to remove renal stone and find an artery which is present in this lower pole which you did not expect, which could be a surprise thing during your surgery. and you do not understand, looks like a thready thing, you cut it down, taper it, and understand that that's the only arterial source that the kidney had, and you already have cut it down. So the kidney is sacrificed. So that's why this particular renal artery or accessory renal arteries are the important thing that you have to keep in mind. Most of the time we forget about this, and that's the problem that we are going to have during surgeries. So that's why this is one of the hazardous thing during renal surgeries. Keep in mind related to this renal accessory arteries. Other than this, other problem related to this particular kidney, as you have seen, this particular kidney have got right side, left side. Now lower side kidney or the lower pole, they are originating from this sacral region. So lower portions of the kidney, right side and left side, may have a common fusion, may not have separated out. They remain unseparated like this, and this particular kidney we call them as horseshoe shaped kidney. It looks like a horseshoe. So as this particular horseshoe kidney is relatively climbing up, it get arrested because these are joined in the lower pole. So this particular arteries which is coming from the ventral part of the abdominal aorta, most notably inframesenteric artery, can arrest the climbing of kidney and can settle the kidney on that particular side. So the kidney ascent may be arrested, that's the point. Well, no problem whatsoever if you have arrest of the climbing of the kidney. The problem may arise out here, this ureter which is present in here. So what happens when this kidney goes to this upper pole, we have a medial rotation of the kidney and ureter placed medial. So hilum goes medial. So this particular kidney, if it is climbing up, not medially rotated, the ureter comes from anterior end, not from medial side, resulting in the coils of small intestine may have present in this particular region and compressing on that particular ureter and the hilum, resulting in the same thing. Urine cannot leak out from or come out from this particular kidney, go outside, resulting in backflow. We call them as hydroureter, hydronephrosis. That's a problem we may encounter. So if we have this kind of developmental error related to this particular kidney, we call them as horseshoe shaped kidney, which has this particular problems, which is known as this arrest of the kidney or upward arrest of the kidney is there. We have this particular problem related to it, and other than this, we have this particular ureter compression may have other chances related to it. Now coming to other problems related to this particular kidney error, we have this particular ureter which is developing from ureteric bud. So ureteric bud which is going to interact with this particular metanephric kidney mass may have interactions, and this particular ureteric bud may have split. That means instead of one may have two ureteric bud to a side, and resulting in bifid ureter. That means the ureter may be two instead of one. The ureter may be two completely separated out, the ureter is separate, and this particular the renal pelvis is separate, and this particular kidney is draining into the output of the urine to this both of the ureter and draining it out. It may have a partial separation, upper part may have two ureter fused to form this particular single ureter, or may have entire tract having two renal pelvis and two ureter there. So we have this kind of error commonly seen as this particular problem or duplications of the ureter as well. So during surgery, this particular problem with this particular renal ureter two or split is another problem. Again, if you have two of this ureter like renal pelvis, we have same problem. They are coming from this hilum, upper pole or lower pole. During the hilum, on that particular region, we have these renal structures like renal vein, renal arteries. Those renal veins and renal arteries may be having interactions with this ureter, may have a compression on them, may have the same problem, hydroureter and hydronephrosis likewise. So these particular problems related to this ureter problem, they may be there. What you have to keep in mind, where from this ureter develops? Ureter develops from that particular point, you call them as ureteric bud. Now, this problem that we call them as urachal defect. Now, urachal defect is a kind of important problem. That's what we have learned it yet. So, this is one of the problems. So, what happens with this kind of problem? We have this particular tract joining this particular anterior abdominal wall or umbilicus to this particular urinary bladder. Now, if we have this particular defect, what happens to this particular kidney, to this particular individual? We call them as weeping umbilicus. Weeping umbilicus means it is dribbling urine through umbilicus. So that's what you are clinically presented with, and this is a exam explain why kind of question. So new year or newborn kid, like 10 years old boy coming to your clinic with her mother or with his mother, complaining of whenever the baby cries, urine pours out through the umbilicus. So whenever the baby is crying, it is pouring urine from the umbilicus. This is the clinical problem that is presented with. Now you have to say that 10 years old individual, how this particular kidney is leaking from the umbilicus or anterior abdominal wall. So for that reason, you have to understand this particular clinical problem related to, we call them as allantois defect. And for this, we have to go back to this particular development of urinary bladder, which we haven't learned it or understand it well. Now for that reason, we have to go back even further beyond. So we start with this particular development of urinary bladder for the development of this factor. We call them as cloaca or cloacae. So what is cloaca or cloacae? It's a blind pouch. We learned about the hindgut developmental part where this particular gut was developing, the hindgut. So that particular hindgut, the lowestmost part is dilated into a blind pouch. We call them as cloaca or cloacae. Now what happens to this particular cloaca? It's split into two parts, anterior and posterior. So anterior one, we call them as urogenital sinus, and the posterior one, we call them as anal canal. So anal canal is formed. How these things are formed? By this partition which is forming over here between this particular cloaca by this septum. We call them as urorectal septum. What is urorectal septum? This is a mesenchymal tissue that is getting into this cloaca and splitting this cloaca into two halves, anterior half and posterior half. The posterior half becomes this anal canal, likewise this, and the anterior half we call them as urogenital sinus. Now you focus on the urogenital sinus. We call this urogenital sinus as primary or primordial urogenital sinus. Now look at this urogenital sinus. This red shadow over here has an anterior communication. This anterior communication we call them as ANNTOIS, allantois. What this allantois is heading to? Is allantois is heading to this particular umbilicus or umbilical ring, this region. So this particular allantois is a kind of connection which this cloaca has ventrally. That particular ventral cloaca connections is separated out by this urorectal septum, and this primary urogenital sinus gets this allantois. So what this allantois over here is present develops into urinary bladder. So why this particular urinary bladder looks like? So urinary bladder develops from this particular green shadow that you are seeing here, this one. So this urinary bladder develops from the source, we call them as urogenital sinus. So what is urogenital sinus? This is anterior part of the cloaca which is separated out, this one. Now this urogenital sinus we call them as primitive urogenital sinus. So this primitive urogenital sinus had three parts, one part, two part, three part. So it has an upper part, we call them as cranial or cephalic part. It has a middle portion and it has a caudal or lower portion. So this green one that you are seeing here, who is having a connection over here with the allantois has got three parts to develop. So, this upper part of this urogenital sinus. So, this particular urogenital sinus, initially it looks like an hexagonal structure like this. So, this part we call them as A with allantois, and we divide this particular urogenital sinus into three parts, 1, 2 and 3. Now, what happens to this part 1? This part 1 balloons out like this. It becomes UB, urinary bladder, and this urinary bladder have this connection, we call them as allantois. Now, this allantois, which this connection should normally become closed, and that particular closed allantois we call them as median umbilical ligament. What is medial umbilical ligament? If you remember this urinary bladder, from the apex of urinary bladder we have a ligament existing. We call this as median umbilical ligament, and this medial umbilical ligament is anchored to the umbilicus or umbilical ring. So, this is what is the fate of the allantois. So, whatever happens to this particular allantois is that normally it should become a ligament. What ligament? Median umbilical ligament. Now, if it fails to become the ligament, it remains as allantois. That means it becomes the tube. So, that tube, if this particular allantois remains patent, so that in that individual the urine can leak out from this particular allantois or patent allantois and leak out through this umbilicus and can create this particular clinical problem. We call them as weeping umbilicus. So, this is what you have to clinically explain. Explain why a 10-year-old kid coming to your clinic with urinating through the umbilicus. So, what you are going to explain? Why this particular individual 10-year-old having this particular clinical problem, and what developmental error that went wrong in that particular individual creating this particular clinical problem with your embryological explanation. So, this is what you are meant to learn in here. So, this primitive urogenital sinus have got three parts. Part number 1, vesico-urethral canal. So, this part becomes balloons out, forms the urinary bladder, and in here urinary bladder we have a connections with this particular allantois which remains. We call them as persistent urachus leading to this weeping umbilicus. Normally it should become this particular clinical anatomical structure. We call them as median umbilical ligament. The second part we call them as pelvic urogenital sinus, which form the middle portions and the philic part of the urogenital sinus like this lower part. So, what happens with this cranial part? It becomes this particular urinary bladder which develops from this upper part. The middle part develops into urethra, full in female, and in case of the male is forming this particular prostatic part of the male urethra. And the third part we call them as phallic caudal part of this urogenital sinus develops in the male only with the penile and the bulbar urethra. So, this is what this whole urogenital sinus develops into. Upper part becomes bladder, the middle portions becomes this particular prostatic part of the urethra, lower part becomes penile or bulbar urethra. So, the whole thing from this particular urogenital sinus is growing into this, and this allantois that you are starting with, this allantois is communicating with this umbilical cord should normally get replaced with this median umbilical ligament. If it fails to replace, we call them as urachus. Now, this particular tract communicates with this urinary bladder cavity to the umbilicus region, and as a result of that, this particular bladder, once this thing fills up with the increased abdominal pressure, like when the kid is crying, the urine is leaking through the umbilicus. So, this is what you have to explain with your anatomical or embryological knowledge, why this particular individual with this particular problem with this weeping umbilicus happens and what this particular clinical problem is meant to. along with this particular 2 clinical problem related to the kidney that you have to learn: ascent of the kidney or accessory renal arteries or duplications of this. So, allantois defect or urachal defect, this is what we call them as patent urachus. What is patent urachus? It is nothing but the persistent allantois, which normally should become this medial umbilical ligament, fails to becomes, creates a tract, so that urine leaks to the umbilicus in that individual. There are other variations of this urachus is there, urachal sinus, diverticulum, cyst, etc. there. You will learn that in surgical divisions later on. For now, only the patent urachus, which is related to these particular problems. Now, coming to this particular problems of this related to this particular genital system development. So, you have to learn about this particular development of the kidney, and related to the development of the kidney is the descent of the kidney, descent of the gonad, that you have to know. Development of the testicles. Into this particular testicles, we have to know about this particular descent of the testicles. Whenever you are learning this particular gonads, we have the ovary and we have the testicles. Both of them develop in the lumbar region, and eventually they do not remain in the lumbar region, they go down. In case of these particular testicles, they move out of the abdominal cavity through the inguinal canal and move out to this particular sac, we call them as scrotal sac. So, this particular total descent of this testis from this lumbar region to the scrotal sac is guided by this particular this particular embryological structure, we call them as gubernaculum. So, this gubernaculum is a fibrous structure that is anchored to the lower pole of the testicles, and this particular gubernaculum shrinks in length, resulting in traction of this particular kidney, tractions to this particular testicles, and it grows down to this particular superficial ring, to this a deep ring, to the inguinal canal, to the superficial ring, and eventually to the scrotal sac. Now, this particular gubernaculum testis is the prime thing. Along with that, it has kind of like a hormonal influence like testosterone. It has a growth of the anterior-abdominal wall and as well as elongations of the anterior-abdominal wall, which is basically helping this out, and increase in the abdominal visceral organ strength, which is basically pushing this testicle out of that. So, these are the things that is helping this particular testicles to move out of this abdominal cavity. Now, when this particular testicles is moving out of the abdominal pelvic cavity, it takes a layer of the peritoneum. That particular peritoneum, we call them as processus vaginalis, that becomes tunica vaginalis in case of this particular gonads, or becomes this particular covering of the testicles. So, this testicles along with this layer of the peritoneum, which basically moves out of the abdominal cavity to this particular scrotal sac. Now, as this particular scrotal sac is movement going on, there is a kind of sequel of the thing which is going on. 3 months iliac fossa, deep ring, 7th month, 9th month, and into superficial inguinal canal to this region, and by 10th month or at term, it reaches to this particular region, we call them as scrotal sac. So, this is the whole story of the descent of the kidney with the time fact. Now, 2 things can go wrong. One thing, the testicles may lose its track. That means, instead of descending to this particular track, it may run elsewhere, and if it runs elsewhere, may settle down there. We found the kidney in malposition. We call them as ectopic testis. Sorry, I may be mixing up with the testis with the kidney because I am running through it, but anyways. So, this particular testicles, if it is running elsewhere from this particular tract, settling down to elsewhere rather than this particular tract, we call them as ectopic testicles. Now, if this particular descent of the testis is slowed and settled down to this particular tract, we call them as cryptorchidism, also known as undescended testis. So, there are 2 entities that can go wrong with this particular descent of testis. So, these things that need to be taken care of. Anomalies of the descent, they may be just like within this particular tract, but delayed, we call them as cryptorchidism, or maybe running elsewhere like perineum or this thigh region or this particular base of the penis, etc., etc. Then we call them as ectopic testicles. So, these two things that you have to keep in mind related to these things. Other than this, as we are saying, these things are coming with this particular fold of the peritoneum or a pouch of the peritoneum which is covering or around this particular testicles. Around that particular processus vaginalis, it may bring coils of the intestine, it may bring fluid inside to it. If it is bringing fluid inside to it and settle down to this particular scrotal sac, we call them as hydrocele. That hydrocele is congenital, we call them as congenital hydrocele. Now, if that processus vaginalis contains the coils of small or any intestine, we call them as hernia. We call them as inguinal herniation. So, that particular herniation which is happening over here is happening in congenital terms, we call them as congenital herniation. So, these two entities that we have to understand over here, congenital inguinal hernia and congenital hydrocele, and why this particular phenomenon is happening. So, this particular hydrocele or inguinal herniation happening because of this peritoneal fold is bringing along with this peritoneum fold fluid or the coils of the intestine. Coming to this particular developmental ovary, the remains with the same, but the story of the ovary descent is different from that particular development or descent of the testicles. Now, with this ovary, the same guide wire which helps to descend, which is known as gubernaculum, is there, just like it was there in testicles. But the gubernaculum, the shortening of the gubernaculum in female subject is interfered by the growth of the reproductive organ, just like the uterus. So, uterus is growing over here in this pelvic organs, and it is growing in between this descent of the ovary, and as a result of that, this gubernaculum is split. So, this particular gubernaculum in case of the female subject splits into two ligaments, and that particular gubernaculum cannot do the tractions completely. So, it splits into this female subject into two parts, we call them as ovarian ligament and the round ligament. So, because of that particular gubernaculum in case of this particular female subjects, we have this particular problem, the descent of this ovary is interrupted by this particular two content. So, this gubernaculum is split into here into two parts, we call them as ligament of ovary, which is known as ovarian ligament, and that particular wrist part of this gubernaculum becomes the round ligament of the uterus. Because of the uterus grows into it and splits this particular entity into two parts, so that this gubernaculum cannot functions properly. Likewise, it was functioning in case of the testes. So, that is why in case of the female subject, that is one of the reason this descent of the ovary is limited to this particular pelvic cavity and not moving out of the inguinal region or moving out of the abdominopelvic cavity. This is what you have to understand into these particular parts or elements of these particular regions. Coming to this particular female organ development in case of this particular female subjects, coming to this particular duct system that you have to keep in mind, we have two duct systems to develop with. We call them as mesonephric duct and paramesonephric duct. Now, this mesonephric duct is the one which remains in the male subject, M for M, and the paramesonephric duct is present in the female subject. That is the first thing that you have to keep in mind. Related to the mesonephric duct in the female, it gets absorbed completely, becomes some rudimentary structures. In case of this male, the mesonephric duct forms this particular outflow of this particular testicular system. That means it forms this efferent ductules, it forms this epididymis, vas deferens, ejaculatory duct, seminal vesicle. So, mesonephric duct basically forms this particular outflow of the testicle system. In case of the female subject, it becomes rudimentary, no important structure. The reverse thing happens in case of the female subjects, there is another duct system, we call them as paramesonephric. In case of the male, paramesonephric duct do not form any structures, the reverse story. The paramesonephric duct forms the female structures or the female objects in case of the female subjects. So it turns into the fallopian tube, upper cranial part which is unfused. The lower part becomes fused, we call them as uterovaginal canal, which forms this uterus. The lower part forms a swelling, we call them a sinovaginal bulb, which eventually forms the vaginal plate and subsequently forms this upper part of the cervix, lower part of the cervix and the vagina. So this paramesonephric duct in the female subject that forms this particular fallopian tube, this particular structure we call them as the uterus, the fundus, body and the cervix, and then with the vaginal tract is developed from this particular paramesonephric duct. And in case of this particular fusion error of this paramesonephric duct, we may have bicornuate uterus, we may have unicornuate uterus, we may have a septate uterus depending on if you have the fusion error with the paramesonephric ducts. So this is related to this in short that you have to keep in mind related to this particular fusion error of this particular like paramesonephric duct of these particular individuals. So this is related to this particular uterus that you have to keep in mind related to this particular female subject developmental part related to this particular organ itself. Now coming to this particular last and the final part of this developmental story, which is related to this particular the GI system development. What you have to learn or what you have to understand, the GI system develops from or develops into tube, and that particular primitive gut tube forms this particular three segments out here. We call them as primitive foregut, primitive midgut and primitive hindgut. Out of that, primitive foregut has one important clinical problem that we call them as tracheoesophageal fistula. So this upper part which transforms into esophagus that has to be separated from this particular respiratory diverticulum, where from this particular lung bud grows eventually. So between this particular primitive foregut tube, we have to develop a partition, we call them as tracheoesophageal septum. So if we do not have a proper tracheoesophageal septum, which should be separating from this particular trachea from the esophagus, we may have a problem, we call them as tracheoesophageal fistula. So if you have a tracheoesophageal fistula, that means the food may enter to this particular respiratory system bypassing this particular abdominal or the esophagus or to this stomach, because this particular anterior position of the respiratory system is a normal bias for this food material to travel into it and results in the choking. So this tracheoesophageal fistula, which is a communication error between the trachea and the esophagus because of the improper development of tracheoesophageal fistula septum. That's what you have to understand. Coming to this particular next clinical problem related to this particular GI system out here, we have to understand this clinical problem. We call them as hypertrophic pyroluic stenosis. That means the pyrulus region of this particular stomach, the musculature is heavy out there and heavily hypertrophic, resulting in narrowing of the lumen. So this particular narrowed lumen on this particular pyroluic region may have a congenital incidence. Then we call them as congenital hypertrophic pyroluic stenosis. Then we have this particular problem over here is that kid born with this particular problem comes with a vomiting tendency afterwards whenever it takes the food, like after half an hour after taking the food, this particular kid throws out all the food material. So we call this clinical condition as hypertrophic pyroluic stenosis. That's what you have to understand into this particular problem. Next thing related to this particular problem, related to this error, we have to understand out here is that the problem with the pancreas development, which is kind of important. So normally the pancreas develops from the bud, one bud anterior, one bud posterior. We call them as ventral and the dorsal pancreatic bud. Now this ventral one moves backwards and joins with this dorsal one, becomes a one pancreatic bud. Now by any chance this ventral pancreatic bud, it instead of one, if it becomes two, we have a clinical problem. Whenever this particular pancreas moving on the back side, it wraps around this particular developing duodenum and encircles it. and resulting this particular problem as annular pancreas. Now, what happens with this individual is the same. The moment this particular kid is taking the food, it stays up to this particular point and beyond that it cannot pass, resulting in the vomiting with this. And in case of this particular problem, with this vomiting is mixed up with this particular content of the biles. That is why the nature or the color of the vomit is bilious, that means green vomiting. So, this annular pancreas is another clinical problem that you have to understand over this particular clinical problem. Next thing about the midgut. In case of the midgut, you have to understand this particular story of the midgut develops from this tube, we call them as primary intestinal loop. Now, this primary intestinal loop develops into the whole intestine system. Now, this particular growth of this primary intestinal loop happens to take place inside this umbilical cord, because we do not have that particular time. So, this particular phenomenon, when this particular primary intestinal loop moves to this particular umbilical cord, we call them as physiological herniation. Now, there is a two things that takes place during herniation. One is the rotation. So, when this particular midgut loop is moving out, we have a 90-degree anti-clockwise rotation. And when this particular midgut loop moves back to the abdominal cavity, it has another rotation 180-degree anti-clockwise. Together it has 270-degree anti-clockwise rotation when it is coming and going out between the 6th week and 10th week. So, this whole phenomenon of this particular physiological herniation of the midgut loop is an exam short note that you have to keep in mind, and this herniation rotation movement takes place around this superior mesenteric artery axis. So, this rotation takes place 90-degree anti-clockwise or 270-degree anti-clockwise around the axis. We call them as superior mesenteric artery, and if we have any error to this rotation error, that means we call them as persistence of physiological herniation. That means the gut loop that came out of the abdominal cavity never moved back, that we call them as omphalocele, where you see that the coils of small intestine or this intestine is wrapped around with this covering. We call them as clistal covering, which have got this particular transparent covering present to it with a deficient anti-abdominal wall. We call them as omphalocele, which the viscera fails to regress back or persists in or physiological herniation. Now, if we do not have this covering, we have even grave problem with this omphalocele variety, which is associated with this deficient or complete or partial anti-abdominal wall deficiency. We call them as gastroschisis. So, these are the two clinical problems related to this physiological herniation or herniation error that we have to understand out here, and related to the problem which is known as the vitalointestinal duct. Now, what is vitalointestinal duct? This particular vitalointestinal duct is a remnant of this vitelline duct that normally again should completely regress. If it fails to regress, it creates a diverticulum. That particular diverticulum we call them as Meckel's diverticulum, also known as ileal diverticulum. That particular diverticulum, if it is present, if it is inflamed, that clinically present likewise the acute appendicitis. So, this persistent vitelline duct or vitalointestinal duct is another clinical problem, just like persistent urachus or persistent allantois that we just discussed about. Now, other than this, we have this hind gut problem, and this is what we started with today's class about cloaca, and this cloaca is separated by this. The cloaca is separated by this urorectal septum into anteriorly urogenital septum, and this particular thing which is separating into urogenital sinus and posteriorly by the anal canal. Now, the anal canal having a membrane, we call them as anal membrane. If the anal membrane fails to rupture, that can create a clinical problem. We call them as imperforate anus. So, this imperforate anus is that where the anal canal is formed, but it is not opening to the anus opening. So, we have this membrane which is present in between them is present as anal membrane, it is failed to rupture there and leading to the clinical condition. We call them as imperforate anus. So, these are the things that you have to keep in mind related to the developmental error into this particular GI system. reproductive system and as well as the urinary system. So, this is all about the session class. For the developmental problems, we are expecting like 7 to 10 mark embryology question out of the clinical, out of the question that is going to be in the write up question, that means theory question. Thank you.